Welcome to the calcium and phosphate pathophysiology teaching. What I plan to do in this first, or I hope to do in this first lecture, is to give you an overview of the physiology of calcium and phosphate metabolism, with a little bit of overlap to pathophysiology, and then in the second lecture use that knowledge to discuss some clinical cases. So here on the first slide is shown a schematic or cartoon of calcium physiology. It looks very complicated, but can be quite sensibly and reasonably broken down into the important components, which are the major hormonal players and the major organs. And so the major hormonal players in the mix are circled on this slide. The most important hormone is PTH, or parathyroid hormone, which provides minute-to-minute regulation of extracellular fluid calcium, which in itself plays an important role in calcium physiology because it is the major regulator of parathyroid hormone production, and as we'll discuss shortly, it's a classical endocrine loop, a negative feedback loop. The other player that's important is the bioactive form of vitamin D, the 1,25-dihydroxyvitamin D moiety, whose production is from the substrate hormone 25-hydroxyvitamin D, is at least in part regulated by parathyroid hormone. It is important to emphasize that extracellular fluid calcium levels are very tightly controlled in physiology, so that the amplitude of levels is very tightly regulated, suggesting that it's an important physiologic phenomenon. In the extracellular fluid, about 50% of the calcium exists in the ionized or free form, and that's the bioactive form. The other 50% is either protein bound, mostly to albumin because that's a very abundant protein, but also to other proteins in the circulation, and about 10% exists in an ion complexed form, and the bound and free forms are in equilibrium. It's the ionized form which is bioactive. It's the ionized form which regulates PTH production. Important contributor. Bone acts as a major reservoir of calcium and phosphate, and kidney regulates the excretion of calcium and is a really important contributor to the rapid responses to perturbations in serum calcium. I mentioned that parathyroid hormone is a really key hormone in the process, and it's often described as the main defender of the serum calcium. It's an 84 amino acid peptide hormone, which is made by the chief cells of the parathyroid glands. Most of us have 4, some of us have 5 parathyroid glands, sit in or near to the thyroid gland at the base of the neck. Sometimes there's an ectopic gland present in the mediastinum, that's the 5th gland. The hormone acts by binding to a G protein coupled receptor, the parathyroid hormone receptor type 1, and as I mentioned, its release is its synthesis and release is regulated by the level of ambient extracellular fluid calcium, and it's a very can be a very rapid response. The hormone sits in the chief cells and already formed and ready for release, so that if there's an acute reduction in the serum calcium, there's a very rapid response in terms of release of preformed parathyroid hormone, and the actions of parathyroid hormone are all to restore the serum calcium to normal, and it does that in three ways. It stimulates osteoclastic bone resorption, so that using the skeleton as a calcium reservoir, that brings calcium out of the skeleton into the extracellular fluid. It also acts at the level of the renal tubule to stimulate reabsorption of calcium that's been filtered at the glomerulus, again acting to restore the serum calcium. Those two effects kick in, particularly the renal effect, very quickly, the bone effect a little bit later, but within minutes to hours of release of parathyroid hormone. And then there's the third so-called long loop effect of parathyroid hormone, which is to stimulate the generation of the bioactive form of vitamin D by stimulating the activity of the renal 1-hydroxylase enzyme that converts 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D. And the 1,25-dihydroxyvitamin D stimulates intestinal calcium and phosphate absorption, and so acts further to restore the serum calcium. So the parathyroid hormones acting either directly or indirectly on each of the three effector organs, intestine, kidney, and bone, that we discussed earlier. So just in a schematic form, this slide kind of demonstrates what happens in response to a perturbation, in this case a reduction in the plasma serum calcium. There's a specific calcium sensing receptor, we'll discuss that in a minute or so, that sits on the surface of the parathyroid chief cells, which senses that reduction in serum calcium and signals to the chief cells to make and release more parathyroid hormone. And the increase in parathyroid hormone acts very rapidly at the level of the renal tubule to stimulate renal tubular reabsorption of calcium. At the same time, it actually causes renal phosphate loss. It acts at the level of the bone to stimulate bone resorption and draw both calcium and phosphate from the skeleton into the extracellular fluid. And it acts also at the kidney level to stimulate the enzyme, the 1-alpha hydroxylase enzyme that converts the precursor of vitamin D, 25-hydroxyvitamin D, to the bioactive form calcitriol, or 1,25-dihydroxyvitamin D, that stimulates intestinal absorption of calcium and phosphate. So you can see that each of those actions of parathyroid hormone is to restore or increase serum calcium. So to summarize parathyroid hormone, or partly summarize, its release is regulated most importantly by the ambient level of ionized calcium. So that level's up, then parathyroid hormone synthesis and secretion is suppressed or decreased. If the level drops, then the response is an increase in parathyroid hormone production. It's also regulated in a positive fashion to some extent by the serum phosphate, because remember I said that parathyroid hormone is phosphaturic, it stimulates renal phosphate loss, so that high levels of serum phosphate and ingestion of phosphate as a pharmacologic agent, for example, tends to stimulate parathyroid hormone production. It's not a major physiologic regulator, but it is one. And the other moiety which can modulate parathyroid hormone production is the 1,25-dihydroxyvitamin D, and again that's it's a negative regulator. So if levels are high, it tends to switch off parathyroid hormone production. just to remind you about extracellular fluid calcium, which is an important player in its own regulation because of its actions on PTH. About half of it is in the ionized or bioactive form. The other half is either complexed with anions such as bicarbonate or bound to proteins, particularly albumin, because it's a very protein that's at high concentrations in the serum, but also globulins. This is a schematic just to reinforce the point that there is a specific cell membrane bound receptor for ionized calcium that sits on the in the membrane of the parathyroid chief cells and binds ligands, ionized calcium, probably also magnesium, but mostly calcium, in such a way that if the level of calcium here in the extracellular fluid is high, the receptor conformation changes and signals to the cells to switch off parathyroid hormone secretion, production and secretion. And so the subsequent reduction in parathyroid hormone release and action will lead to restoration of the calcium level back to the physiologic range. And it follows then that, as we'll see later on, that if this receptor function is disordered, either it's constitutively switched on or there are mutations which inactivate the receptor, then those conditions will lead to perturbation in the calcium parathyroid hormone axis, and such conditions are now clearly and have been elucidated and clearly described. The other thing that the calcium sensing receptor is expressed actually in many parts of many tissues in the body, the brain and many parts of the gut, where its function is less well understood. But the other thing that it plays a role in, independent of parathyroid hormone and calcium physiology, is in renal tubular calcium handling, where it is expressed on the basolateral membrane of the renal tubular cells. So here's the renal tubule here, here's extracellular fluid, and again the receptor senses ambient, the extracellular fluid calcium levels, and in response to those levels can modulate the reabsorption of calcium from the urine back into the extracellular fluid. So if there's lots of calcium here in the extracellular fluid, in physiology the receptor will signal to reduce further reabsorption of calcium from the renal tubule into the extracellular fluid. One of the other major players, or the other major hormonal player in calcium metabolism, is vitamin D, and shown here is a schematic of the fundamentals, if you like, of vitamin D metabolism. It's a relatively complex system, but the important points to note are that in physiology, firstly, it's not a vitamin, it's a hormone. Vitamin is something that we have to take in the diet. You can be perfectly replete in vitamin D without taking any in the diet, because it's in fact a hormone that's made as the result of sunlight exposure, specifically UVB radiation, which activates precursor molecules in the skin, in the dermis, and then through a series of precursor steps that includes an hydroxylation step at the 25 position, produces the main body store of vitamin D, which is 25-hydroxyvitamin D. It's the one that, if you wish or need to measure or assess someone's vitamin D status, the metabolite to measure is the 25-hydroxyvitamin D level. It in itself has little biologic activity, but serves as a precursor for the biologically active form, which is the 125 dihydroxyvitamin D, which we talk calcitriol that we talked about earlier, which is produced as a result of hydroxylation of 25-hydroxyvitamin D in the kidney by the 1-alpha hydroxylase enzyme, which, as we discussed earlier, is importantly regulated by parathyroid hormone, which activates the process, but also by the level of ambient phosphate, and it is such that low levels of phosphate stimulate the production of that or the activity of that enzyme, and thereby the production of the bioactive form of vitamin D. And its main role in calcium physiology, really its critical role in calcium physiology, is then to stimulate active absorption of calcium and phosphate in the intestine, and thereby act to increase levels in the serum of both calcium and phosphate. There are a number of checks and balances in this system with catabolic pathways in the liver and in the kidney, which generate the production of probably inactive metabolites of vitamin D. An important point, which a very important point to note, is that calcitonin, which is another hormone that's made in the it's made this time by the thyroid, C cells of the thyroid. It's not a physiologic regulator of serum calcium, despite what you might read in some of the older textbooks. But we can happily do without calcitonin. That is, in people who've had thyroid removed. Doesn't affect their calcium physiology. The other player that you need to know about is paracrine hormone, called parathyroid hormone related peptide, or PTHRP. And in physiology, that's an important paracrine, that is a hormone that's acting at the tissue level, not as a circulating or endocrine hormone. It's a paracrine regulator of breast, skin and bone development, so it's an important developmental molecule. In physiology, it's not a regulator of serum calcium, because in physiology the amount of this hormone that reaches the circulation is negligible. Where it does become important in calcium physiology is in states of pathophysiology, when it's produced in excess by some cancers, especially epithelial cell cancers, but actually an enormous range of cancers have been described as overproducing this hormone. When it does get into the circulation, and it's able, when it's present in the circulation in sufficiently high quantities, to mimic the actions of parathyroid hormone, because it has structural homology with parathyroid hormone. Can interact with the parathyroid hormone receptor and cause the same effects, which are to increase the serum calcium. And so in these situations, in so-called malignant or humoral hypercalcemia of malignancy, patients may experience hypercalcemia, which can be quite severe and life-threatening. In fact, this is the most common cause of cancer-associated hypercalcemia. We'll talk about that a little bit later when we get to the cases, but an important clinical point is that in situations where cancer-related hypercalcemia is present, it's almost always the case that by the time the patient becomes hypercalcemic, the cancer is either known or is easily detectable. So it's very unusual for this to be a signal of occult cancer. But it is a really important clinical problem. And so that's the final hormonal player that you need to know about in relation to the physiology / pathophysiology of calcium metabolism. So with that in mind, what are the causes of hypercalcemia that one comes across in clinical practice. And when you think about what we've just discussed, clearly parathyroid hormone is a really important player in this process. You can divide the causes of hypercalcemia into those which are parathyroid hormone dependent, that is driven by production of or excess of parathyroid hormone, and those that are parathyroid hormone independent, that is parathyroid hormone is not the driver of the process. The much more common is the other parathyroid hormone dependent causes, and of those, overwhelmingly the most common is primary hyperparathyroidism, which is a disorder that's almost always caused by a solitary adenoma of one of those 4 parathyroid glands that sit in the base of the neck, occasionally caused by hyperplasia of those glands, so all of the glands are contributing to the parathyroid hormone excess. Much more rarely, but well described, the parathyroid hormone dependent hypercalcemia can be caused by mutations in the calcium sensing receptor, which decrease its function, so that the cells and the chief cells in the parathyroid glands are tricked, if you like, by the receptor mutation, inactivating receptor mutation, into thinking that the ambient extracellular fluid calcium is lower than it actually is, and as a consequence parathyroid hormone generation and release increased, and the typical biochemistry of parathyroid hormone dependent hypercalcemia is present. The serum calcium is raised above the normal range, and the parathyroid hormone levels are either clearly raised or inappropriately normal. When you think about it, if physiology is present, then raising the serum calcium should switch off parathyroid hormone production. So the important, if you like, combination of biochemical abnormalities in parathyroid hormone dependent hypercalcemia is an elevated serum calcium and a normal, inappropriately normal or elevated parathyroid hormone production. So you can see that if a patient in clinical practice is found to have hypercalcemia, the next test that's going to be helpful is to measure the parathyroid hormone, and that allows you then to differentiate or to place the patient in one of these 2 categories, the parathyroid hormone dependent or independent disease. What about the parathyroid hormone independent diseases? These patients will have elevated serum calcium but a suppressed or unmeasurable parathyroid hormone, because that part of the system is intact. They have an appropriate parathyroid hormone response to the elevated serum calcium. And the causes of that, there's actually, if you look in the textbooks, quite a long list, but they fall really into 2 major branches. Most commonly amongst the parathyroid hormone independent hypercalcemic conditions is cancer, and as we discussed, that's almost always relating to excess production by the cancer of that hormone, or the peptide, parathyroid hormone related peptide. Can also be caused if the cancer is involving the skeleton, causing a lot of bone resorption, which floods the extracellular fluid with calcium, and particularly is likely to occur if the ability to excrete that resorbed calcium is diminished, that is in patients with some impairment of renal function. And the disease which is very classically, or a very classic example of that phenomenon, is multiple myeloma, where there can be very extensive skeletal involvement with a lot of very intensely resorptive or lytic bone lesions. A rare cause of cancer-associated malignancy, usually only seen with hematologic malignancies such as lymphoma, some leukemias, is that the tumoral tissue is able to express the 1-alpha hydroxylase enzyme, which converts 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D, that causes hypocalcemia by stimulating a hyperabsorption of calcium from the diet through the gut. So very rarely cancer can cause a vitamin D dependent, if you like, hypercalcemia. More commonly in the vitamin D dependent parathyroid hormone independent hypercalcemic syndromes is granulomatous disease, and specifically sarcoidosis, where again the granulomatous disease has the ability to elaborate in the 1-alpha hydroxylase enzyme, which converts the 25-hydroxyvitamin D precursor to the 1,25 active moiety, which stimulates gut hyperabsorption of calcium. Even more really, but occurs occasionally, people who take or are administered too much vitamin D precursor convert enough of it to the active form of vitamin D to produce vitamin D intoxication. I think if you know that list and have that schema in your mind for thinking about clinical situations of hypercalcemia, then you'll be able to deal with most cases that come along. What about hypocalcemia, the flip side? And here again, there's actually, if you look in the textbooks, a very long list of causes, but most of them are extremely rare. And again, thinking about the importance of parathyroid hormone as a regulator of serum calcium, shouldn't surprise you to know that parathyroid hormone deficiency is the most common cause of hypocalcemia, outside, I should say, of renal failure, which we'll talk a little bit about later on. And the most common form of hypoparathyroidism is actually iatrogenic. That is, individuals who've had surgery often to the thyroid gland, and the parathyroid glands have been damaged as a result of that surgery, and are unable then to produce enough parathyroid hormone to maintain the serum calcium. Much less commonly, but is described, and it's less common now because external beam radiotherapy is not as commonly used, but previous X-ray therapy to the head and neck can in the long term damage parathyroid hormone function and lead to hypoparathyroidism. Mentioned earlier, that's rare cases of hypercalcemia caused by inactivating mutations in the calcium sensing receptor. The flip side can also be present, can also occur that individuals can have activating mutations of the calcium sensing receptor. The receptor is constitutively activated, so telling the parathyroid chief cells to reduce, to reduce parathyroid hormone production, even though serum calcium levels are low. So that situation can mimic, if you like, hypoparathyroidism. It's a form of hypoparathyroidism. An important one to just keep in the back of your mind is that magnesium, very low levels of serum magnesium, impair, in a way that's not terribly well understood, but impair the ability of the parathyroid gland to respond normally to calcium signaling. And so severe hypomagnesemia, which is pretty uncommon but does occur in people with significant bowel disease, and rarely in people taking proton pump inhibitors such as omeprazole. The hypoparathyroidism can be corrected by restoring magnesium levels into the normal range. Hypoparathyroidism can occur as a result of autoimmunity. It's probably the second most common cause of hypoparathyroidism, and really it can occur as a result of infiltrative diseases such as copper excess, Wilson's disease, and iron excess, beta thalassemia, or individuals who've had lots and lots of blood transfusions. Iron can accumulate in the parathyroid glands and damage the cells, the glands, sufficiently to cause functional deficits. Parathyroid hormone resistance, I'm going to talk a little bit about that, can occur as well. These are individuals who have plenty of parathyroid hormone, but the signaling to the effector tissues is impaired by mutations which inactivate important proteins in the signaling cascade that communicates the extracellular parathyroid hormone signal to the cells. And typically those individuals will have low serum calcium because the parathyroid hormone is not working, but have quite high levels of parathyroid hormone because the negative feedback loop is intact. The problem is that the parathyroid hormone is just not able to signal to the tissues of importance. The other important cause of hypocalcemia is abnormalities of vitamin D metabolism, and here the two most important ones are vitamin D deficiency. You remember that we talked about the physiology of vitamin D, the importance of sunlight. Individuals who are sunlight deprived and those frail, institutionalized elderly or housebound elderly individuals who just don't get out in the sun, or individuals with deeply pigmented skin who also avoid the sun, and individuals who for cultural reasons wear veils and long sleeves and therefore reduce sunlight exposure. Those are the groups in the population who are at risk of vitamin D deficiency. And vitamin D deficiency, if it's severe enough, will lead to impaired calcium and phosphate absorption from the gut and hypocalcemia, and the kind of phenotype, an important phenotype is osteomalacia, or impaired mineralization of bone because of calcium and phosphate deficiency. Individuals with advanced renal failure have impaired ability to make the bioactive form of 125 the active form of vitamin D, which is 125 dihydroxyvitamin D, because you remember the 1-alpha hydroxylase enzyme is expressed in the kidney, and those individuals will therefore often have hypocalcemia. This is an advanced renal failure, and it's important therefore in individuals whom serum calcium is found to be low, to check what the renal function is. So talk a little bit about phosphate metabolism as we're getting towards the end of this part of the presentation. Again, this is a complicated slide, but you can think about phosphate metabolism in the same way as calcium metabolism, really. Think about the major hormonal players and the major organs involved. And there's quite a bit of overlap, as you've already would have surmised from the first part of the lecture, between calcium and phosphate metabolism, and one important difference. So here I've asterisked the important hormonal players that overlap with the calcium metabolism, so vitamin D, and specifically that 125 dihydroxyvitamin D, plays an important role in the absorption of phosphate from the diet at the intestinal level into the extracellular fluid. And parathyroid hormone plays an important role in modulating the flux of phosphate in and out of bone. Remember, PTH tends to stimulate bone resorption, and therefore the flux of phosphate from bone into the extracellular fluid. The other thing that PTH does is, at a kidney level, stimulate the excretion, so it's a little bit phosphaturic. So individuals with PTH excess tend to have low normal or slightly below normal levels of serum phosphate. The difference, if you like, between in the hormonal regulators between calcium and phosphate metabolism is the phosphatonins. These are a group of proteins which have been relatively recently elucidated, which specifically, importantly regulate the renal excretion or handling of phosphate, such that they tend to stimulate phosphaturia. So if they're present in excess, renal phosphate wasting occurs and serum phosphate levels tend to fall, and if they're present in high enough levels, that reduction in serum phosphate can cause clinical sequelae, specifically impairment of bone mineralization, because that process needs adequate amounts of both calcium and phosphate. And the most important of the phosphatonins discovered to date anyway is a protein called fibroblast growth factor 23, or FGF23, and we'll be talking a little bit more about that later on. This slide just asterisks the important tissues involved in phosphate metabolism. They are the same as they are in for calcium metabolism, the gut, because that's where phosphate is absorbed from, and there's hormonal influences there. The bone, because the skeleton is a major kind of repository of calcium and phosphate, and bone resorption tends to pull phosphate out of bone as it does for calcium. And the kidney, which is a critical regulator of day-to-day handling of phosphate. And here's shown important contributors, if you like, to the sort of integrated outcome of phosphate metabolism, which is the level of phosphate in the extracellular fluid. So what we take in our diet is somewhat important, although it's very hard to become phosphate deficient from dietary causes, because phosphate's so ubiquitous in the diet. Much more important contributor to the measured level in the extracellular fluid is the fluxes that occur between intracellular and extracellular fluid. And a really important clinical point is that many illnesses, because they cause respiratory alkalosis from hyperventilation, stimulate the movement of phosphate from extracellular to intracellular stores, meaning that many individuals who are sick and in hospital will have lowish or even below normal levels of serum phosphate. It's almost never a problem that causes in and of itself clinical sequelae, and the important part of management is to correct the underlying illness and restore pH to normal, and that will lead to re-equilibration and normalization of the extracellular phosphate levels. And the kidney is a really important focus, if you like, for regulation of phosphate, and it's the source of, or the tissue responsible for hypophosphatemia in most of the conditions in which which are associated with clinical sequelae of the hypophosphatemia. So hyperphosphatemia, high levels of serum phosphate, how do they come about? Really, because of increased input, because people are getting intravenous, so just loading with serum phosphate. If there's widespread tissue necrosis, sometimes it happens with major trauma or burns, or sometimes with in the treatment of malignancies with rapid onset of tumour cell death. Much more important cause of hypophosphatemia is impaired excretion, and remember the kidney is the main organ involved there. So most commonly impaired renal function. So once the EGFR gets down below around 30 mils per minute, serum phosphate tends to rise, and hypophosphatemia is a very common biochemical accompaniment of impaired renal function. Mild hypophosphatemia can be seen in states of parathyroid hormone deficiency or resistance as well, because remember phosphate, PTH is a phosphate wasting hormone. What about hypophosphatemia? And here, as I mentioned, it's virtually impossible to become hypophosphatemic, principally because of dietary lack. So you can think about that in terms of intestinal causes, and most commonly that's going to be inadequate absorption, and particularly accompanies severe vitamin D deficiency. The most common cause probably is this intracellular shift phenomenon that we talked about, that's driven by respiratory alkalosis in ill individuals. It's usually self-limiting because the underlying problem is treatable, and restoration of normal pH leads to re-equilibration. It is a phenomenon that can be seen and has been reported in refeeding of malnourished patients, hypophosphatemia. And then in the clinical setting, renal losses are pretty important, and so states of parathyroid hormone excess tend to lead to lowish or slightly low serum phosphate levels. High levels of those phosphatonins, particularly FGF23 that I talked about, which can occur in some pathophysiologic states, either inherited conditions or acquired conditions, such as tumoral production of FGF23, cause renal phosphate wasting, and so does chronic alcohol abuse. This slide's just to reinforce the idea that in acute illness, which is accompanied by hyperventilation and respiratory alkalosis, there is a sort of drive for serum for phosphate to move from extracellular to intracellular stores, which is then reversed as the alkalosis resolves. The phosphatonins we talked about, FGF23 is the one that's most important. It's actually derived from bone, and specifically mostly from the osteocytes, terminally differentiated osteoblasts that sit in the bone matrix. And it causes phosphate waste. It causes hypophosphatemia by impairing by reducing the expression and activity of phosphate transporters in the renal tubule, these sodium phosphate 2A and 2C proteins that leads to decreased phosphate reabsorption from the proximal tubule and consequently hypophosphatemia. It also is quite a powerful inhibitor of the 1-alpha hydroxylase enzyme that's leads to the production of 1,25-dihydroxyvitamin D. So FGF23 reduces the levels of 1,25-dihydroxyvitamin D, which you'll remember stimulates phosphate absorption at the intestinal level. So FGF23 either directly or indirectly leads to decreased phosphate reabsorption at the kidney level and decreased phosphate absorption from the gut, and both of those contribute to the hypophosphatemia that accompanies the excess levels of that hormone. That just shows schematically that the expression of these sodium phosphate transporters in the renal tubule is regulated by PTH to some extent, but more powerfully by FGF23. So when one thinks about phosphate losing conditions, you can think that the major players that we've talked about, PTH 125, FGF23, will be involved. So FGF23 normally in physiology comes out of the bone, specifically made by osteocytes in the bone, these cells that sit in the bone matrix and communicate with each other via these long tendril-like processes and communicate with the bone surface in that way. And FGF23 in physiology inhibits that 1-alpha hydroxylase and so reduces the production of 1,25-dihydroxyvitamin D and thereby gut absorption of phosphate. It also inhibits phosphate transporters in the proximal renal tubule and increases renal phosphate loss. Both of those things in combination lead to hypophosphatemia. FGF23 is in part regulated by proteases, one of which is encoded by a gene called FEX, which, if mutated, is an X-linked hypophosphatemia, leads to impaired catabolism of FGF23, elevated levels, and hypophosphatemia through the mechanisms we've just discussed. So how might one how might high levels of FGF23 be achieved and thereby cause hypophosphatemia? Well, FGF23 is sometimes elaborated by tumours. These are usually benign tumours, often quite difficult to find, so occult tumours, derived from mesenchymal cell origin, so often fixed to or part of the skeleton or cartilage. These tumours make and secrete FGF23 at levels which exceed the ability to inactivate the protein, and those high levels of FGF23 cause hypophosphatemia because of the effects on the 1,25-dihydroxyvitamin D and renal phosphate handling. We mentioned the FEX enzyme, which is mutated and inactivated in X-linked hypophosphatemia, an inherited condition leading to impaired catabolism of FGF23, so levels are high and hypophosphatemia ensues. Mutations in the FGF23 gene itself that lead to changes in the protein that make it resistant to the normal levels, the normal processes of catabolism are described, and that's an inherited condition, and it's usually autosomal dominant. Those are rare but well described.